welcome to everyone to this ATI seminar on February 14th. First off, I'd like to start with a land acknowledgement based on the University of Alberta, where this is being hosted. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Thank you to Paladin, Astellas, and AstraZeneca for the support of the ATI seminar series, this one and ongoing. I'm Stephen Congley. I'm a transplant hepatologist based out of the University of Calgary. It's my pleasure to moderate today's seminar by Dr. Selzner and Chaudhury, talking about liver transplantation for alcohol-associated liver disease, what's beyond 6 months of abstinence. And certainly, things have changed from when I first started training, when 6 months was a hard rule. I look forward to hearing from the two of them about where we go from here. Dr. Nazia Selzner is a transplant hepatologist and is the medical director of the Living Donor Liver Transplantation Program, the Mera Transplant Center, UHN, and associate professor of medicine at the University of Toronto. She's also a scientist at the Institute for Medical Science in Toronto. She graduated from medical school at the University of Paris 7 in France and completed her GI training in France. She did her PhD in 2003 at the University of Paris 7 after 4 years of research fellowship at Duke University Medical Center and the University of Zurich. Her research interests are in the mechanism of ischemia and reperfusion injury of the liver, with her clinical research focused on increasing access to liver transplant and living donor liver transplant. She is a recipient of numerous national and international awards and has published extensively in the area of living organ donation, transplantation, and reperfusion injury. She's also the current president-elect of the International Liver Transplant Society. Dr. Prosanto Chaudhury joined the Department of Surgery at McGill University in July 2007 after completing his fellowship training in transplantation and hepatobiliary surgery. He received his master's degree in evidence-based healthcare from the University of Oxford in fall 2007. Since his return to McGill, his clinical activities have been based at the Royal Victoria Hospital and centered on the treatment of complex hepatobiliary oncology, as well as organ transplantation. Dr. Chaudhury has an active interest in the use and outcomes of organs from DCD donors, has helped introduce DCD donation in Quebec. He's a surgeon champion for the American College of Surgeons National Quality Improvement Program, the largest and most effective benchmark surgical quality improvement program in North America. He's been heavily involved in the teaching of evidence-based medicine, both at the undergraduate and postgraduate levels, and he's the theme leader for evidence-based medicine in the undergraduate curriculum at McGill. With that, I turn over the floor to our esteemed presenters, Dr. Selzner and Chaudhury. The floor is yours.
So what we are going to do is we are going to talk about liver transplantation for alcohol-related liver disease, obviously, and I will start with our program in Toronto that we started in 2018 and walk you through this program and where we stand with it and our outcome, and then Dr. Chaudhury will talk about the leading liver practice in terms of alcohol-related liver disease that also we initiated a few years ago, and summarize that effort, which was also supported by Canadian Blood Services. So without further ado, we all know that until not that long ago in Canada, all Canadian centers were following the rule of 6 months abstinence for transplanting patients with alcohol-related liver disease. This was in fact a CLTN policy in 2011, and there are a number of factors that are considered as pro for having a period of abstinence from alcohol, whether it's 6 months or longer or shorter, in terms of opportunity for the liver to have recovery. And there are some suggestions that perhaps a period of abstinence can demonstrate the ability of the patients to remain abstinent from alcohol. It's a clear, concrete metric to follow for many of us. However, we also know that this rule is not fair and just. It's associated with a high mortality rate for some of the patients, including those with acute alcoholic hepatitis who don't have a period of 6 months to wait. And there is really no good data supporting the fact that a period of 6 months abstinence is indicative of future relapse. And we also all know that generally the outcome of patients who have been transplanted for alcohol-related liver disease is good. And in fact, for example, this is a study that was published not that long ago using a UNOS database, looking at up to 10-year survival, graft and patient survival of patients with alcohol-related liver disease that were transplanted in the US with over 4,000 patients in this, almost 4,000 patients in this study, and comparing them to outcome of other indication for transplant. And as you can see, the long-term outcome is excellent. Even if we look at more recent studies that have taken into consideration outcome of transplant with obviously shorter follow-up data of transplanting patient with less than 6 months abstinence or early transplant, they call it ELT, versus those who were standard and follow the 6 months abstinence rule. Again, this is a smaller number of patients, but you can see up to 3 years follow up the outcome in terms of both graft and patient survival is equal to those that wait for a longer period of time. We also know that post-transplant relapse is not very well defined in the literature. And when we look in the published report on this, anywhere from 15 to 50% rate of relapse is reported. Part of it is due to the fact that the data are in some centers are self-reported by the patient. So we are not sure if how many patients in fact admit to the fact that they return to drink post-transplant. There is no clear definition of relapse. Some people call relapse if someone drinks a drink a month, as opposed to those who drink daily and significantly. Most of these previous studies were single center, and most of them were following the rule of 6 months. But generally, there is understanding in the literature that harmful relapse that results in loss of graft is anywhere between 10 to 25% post-transplant. Now, more and more data has been generated in the last year in terms of rate of relapse for patients with less than 6 months abstinence. This is one of probably the most referred to study. That's the Accelerate study from the US that was published in gastroenterology a few years ago, and that's a multi-center consortium study that brought the data from 12 centers in 8 UNOS region together. It's a retrospective study and looked at those who received a transplant without waiting for 6 months with no period of sobriety. And they have about 147 patients in this study. And as you can see, the survival, of course, at 1 year and 3 years of post-transplant was great, 94 and 84%. And the sustained alcohol use after transplant was at 10% at 1 year and 17% at 3 years post-transplant. And the same group have recently reported the outcome with 5 years follow-up of these patients, with the same patient in the Accelerate group. And this time they have separated the patient based on whether they were remaining completely abstinent, whether they had early and heavy drinking versus early but no heavy drinking, as opposed to late onset of drinking, but heavy. And what is important to look at this, the slides here, you can see that with 5 years follow-up, those who had early but heavy drinking, about 50% of those patients, their probability survival was 50%, and even those who had the early and non-heavy drinking, their survival rate was their probability of survival was not what we want our patients to be. So taking all these things in consideration, and also due to the fact that in Ontario, as well as many other provinces in Canada, we faced a number of lawsuits and challenges in terms of transplanting patients for alcohol-related liver disease, we decided in 2017 to embark ourselves into a new route where we take our patients for considering our patient with alcohol-related liver disease, not just on the basis of this 6 months period, but taking into consideration other parameters. So what are those parameters, and what was the goal of this so-called ALD program, pilot program? It was to identify patients with alcohol-related liver disease who are deemed to have a good prognosis with respect to their risk for relapse. To also operationalize a multidisciplinary team approach to assess suitability for transplant, and also provide help to this patient and support post-transplant. And then eventually our goal was to look at the equity and utility of this 6 months rule, and to see whether we want to follow up with that in Ontario. So our whole program is based on a holistic approach, but also taking into consideration that this is based on an integrated addiction team. While in the past, patient with alcohol-related liver disease was mostly seen by the hepatologist, going to workup after 6 months and being transplanted and followed by the transplant hepatologist, now we have set into practice a number of other parameters that is based in bringing together a team. We also look for early identification of risk factors that are modifiable. We improve access to treatment for alcohol use disorder with potential to avoid need for liver transplant if possible. It's a more patient-centered, and therefore the patient buy into this program. And it also improved the communication and collaboration between the hepatologist, but also mental health provider. And also helps us to detect earlier return to drink post-transplant, and I will show you some of our results with prompt intensification of supports that helps again bringing this patient back to the road of remaining abstinence, and also reduce post-transplant alcohol use. So these were all the benefits that we had in mind as we started this program. So on looking for other parameters that would allow us to better define relapse, we felt that there are a number of parameters that are helpful, including biological parameters, such as severity of alcohol use disorder, evidence of other comorbid substance use disorder, family history, age, gender, but also psychological parameters, including insight into alcohol use disorder, motivation to maintain abstinence and follow with the treatment for alcohol use disorder, as well as social parameters, such as having social support, home environment, housing, income, etc. And this concept of integrated care for ALD is based on 3 pillars: assessment of the patient, providing them treatment, and monitoring them. When it comes to assessment, we look at this, obviously their medical suitability for a transplant in general. That's similar to every other transplant recipient. but we also look at their psychosocial suitability. And by this, we take into consideration their willingness to commit to abstinence, the severity of alcohol use disorder. For this, we use DSM-5 criteria, the relapse history in the past, other substance use, as well as other psychiatric history, and adequate support network and stable housing. In terms of the treatment, all these patients obviously are seen by a transplant psychiatrist. The goal is to mitigate the risk for relapse post-transplant. All the patients with alcohol use disorder must be willing to participate in relapse prevention treatment that is provided as part of this program to all the patients, and pre-transplant, if possible, and post-transplant by a therapist. We don't consider Alcohol Anonymous as a relapse prevention treatment. This is an additional support if they want. And as I mentioned, a dedicated specialist will work directly with this patient or link them to counseling or other resources that is available to them in their community. And then monitoring, so we look for evidence of alcohol use. We commonly use urine ETG. That's the one that is easiest for us to obtain here, or serum CDT post-transplant. And we have now access also to PET, and we try to use that a little bit more frequently, although it's not yet fully covered and we don't have it in hospital. At time we use PET to look for more interval of period for alcohol use. So this is the outcome of our study that we started, as I mentioned, in 2018, and we analyzed our data at 3 years and published that. So that was from May 2018 to October 2020. As you can see here, this is a very complicated chart, and I don't want you to focus too much on the details, but the steps is that we take in all the referrals. All the referrals is assessed, triage and assessed. If it's a clear cut, we briefly discuss it during our weekly meeting. Otherwise, they are all seen by hepatologists, by the addiction specialist, social worker, and then we rediscuss them again during our weekly meeting. And if they seem suitable, then we process to medical evaluation at that time. And when we started, and by the time we reported the result of this study in period of not a bit over 2 years, we have received 700 or 800 referrals just for this study. And that slide shows the average length of abstinence for the patient that we looked during that time period. You can see here we have patients who had no period of abstinence, but we also had patients that were abstinence after 2 years. And the reason we do that is we decided that every patient with alcohol-related liver disease should be assessed based on the length of this study, and regardless of the fact that they may be more than 2 or 3 years post abstinence at the time of the referral, and the average length is somewhere around 4 months. Many of the patients in the study were in the moderate to severe alcohol use disorder. Of the 300 change patient that went forward, but you can also see that there are patients who have no criteria, don't meet the DSM-5 criteria for alcohol use disorder. And when we looked at the post-transplant return to alcohol use, we only had 3 cases out of 44 that were transplanted at the time where we published this study, and the rate of relapse was only 6.8%. And when we compare this rate of relapse to our previous reported rate of relapse in our program for those patients that have been abstinent, so-called, more than 6 months after they were transplanted, the rate of relapse was 3 times lower. And again, this is a self-reported rate of relapse because we weren't monitoring really the patients at that time. And you can see that is still much less. These are brand new follow-ups. We haven't published it. We are in the process of looking and finalizing this manuscript. So since then, we have transplanted a lot more patients, and we had some more further relapse. We had 19 out of 165 that had some relapse to alcohol. But what is very encouraging, and I want to draw your attention to that, is that out of these, 15 from 19 of these relapse patients were engaged again in the AUD treatment, and 16 out of those 19, 84%, have reestablished abstinence and maintained abstinence. And the way we diagnose this relapse is some of them had, very few of them, in fact, had elevated liver enzymes. And majority of them was through the biomarker monitoring that we are doing, and a few were also self-reported. So with this, I will follow up and let Dr. Chaudhury talk about the leading practice. But we believe the evidence to support the 6 months is mixed at best. The outcome of the patient with less than 6 months that are transplanted could be very good as long as we establish something more than just transplanting them and sending them out to regular follow-up with just the hepatologist. Thank you so much. Have I stopped sharing, or you are still seeing my
No,
screen?
we're good. And I think that you should all be able to see my screen now. Nazia, if you give me a thumbs up to see that they can see.
Very good.
Perfect. So the question is, why are we here, I suppose, talking about this topic? And I think Dr. Selzner has done a good job of setting the stage. But perhaps to say that, you know, in Canada, we actually transplant a significant number of our adult liver transplants for alcohol-related disease. And that number has gradually been increasing over time. As Dr. Selzner mentioned, the 6-month rule is one that was historically applied for a variety of reasons that were mentioned already. The ability of the liver to recover, the feeling that this may, in fact, decrease the risk of return to post-transplant drinking, the assumption that post-transplant drinking automatically leads to worse outcomes. It's quick and easy to apply, and we've had very good outcomes using this rule. But there have been challenges that are not, strictly speaking, medical challenges to it, but rather challenges under human rights, provincial human rights codes. The CST put together a white paper on substance abuse and transplantation, kind of in anticipation of the legalization of marijuana. And they talked about all substance abuse in that document. And this was around the same time as the first legal challenges to the 6-month rule were happening, and the beginnings of the pilot project in Ontario. So this led to a certain amount of discussion at the Canadian Liver Transplant Network meetings in 2018 and 2019. With CBS, we thought that this would be a great joint venture for CBS and CLTN to try to establish some kind of a national approach to this problem. So we actually started planning this many years ago. However, there were certain unforeseen national pandemic-related events that slowed things down somewhat. And so things that were originally anticipated to be in person became virtual, kind of like this presentation today. We created a steering committee and looked at what kind of processes we'd use to develop these guidelines. And we undertook several projects, some of which are still ongoing today, and convened the beginning of the process as a national series of fora or webinars. Some of the preliminary work we did was consulted a variety of transplant centers across the US, the UK, all the Canadian ones, and some European ones as well. And we found, not surprisingly, that there was a great deal of variability in regards to how people were selecting patients with alcohol use disorder for transplantation. Many focused on pre and post-transplant treatment and support to prevent relapse, but at the same time, there's a great deal of variability around the availability of these resources in different populations. In addition to just looking at the medical side of things, we partnered with Jennifer Chandler and Vanessa Grubin from the Faculty of Law at the University of Ottawa to examine the ethical and legal principles and how a new set of recommendations might be challenged or stand up to human rights challenges. So the forum was finally held in 2022. In addition to the forum, we had or have been working with Marilyn Swinton from McMaster to develop some qualitative research into how different stakeholder groups perceive limitations around the use of alcohol and what's reasonable and not reasonable from their perspective. We also worked with Carolyn Tate, who I think has migrated to your institute over time, to explore Indigenous perspectives on this, as we felt this was also an extremely important issue to bring to light. So this is, again, qualitative work involving First Nations and Métis patients. And her work revealed some themes that are perhaps not surprising as well in the communities, centering on the early onset of alcohol use, the impact of intergenerational trauma, the significant gaps in alcohol treatment programs, communication with their healthcare providers, geographic barriers, the timing of intervention, the stigma, and the ongoing impressions of racism in regards to this. In terms of developing the actual content of our recommendations, we engaged with two methodologists, Joanna Dion and Simon Oshkowski, and with the steering committee aimed to try to bring the evidence together around the evidence around the 6-month rule, differences in patient outcomes, trying to define or at least assess what people use to define recidivism, and see what programs and criteria were being applied. So our steering committee met, and we developed a series of PICO-formatted questions around these general themes. We prioritized the outcomes and developed eventually a systematic review methodology with a search strategy, working with medical librarians, screening, independent verification of all the data, and then data extraction, assessment of risk of bias, and so forth. So fairly rigorous methodology applied in order to extract data around these PICO questions. I'll put the PICO questions up very quickly, but they're not by any means exhaustive. So looking at first outcomes after liver transplantation for alcoholic liver disease, the outcomes once you have returned to drinking, evidence for the rationale for the 6-month abstinence, definition of recidivism, the rate of recidivism as it's reported, risk factors and protective factors for recidivism, what other criteria or assessment tools that may predict relapse can be used, and what interventions that could be offered to patients to help prevent relapse. Overall, some 6,000 records were screened leading to eventually 140 studies that were included in our review. So when it comes to the rationale for the 6-month rule, we conducted, or we were able to put together a narrative summary of the published articles. It was surprising to all of us that the actual development of a 6-month rule was rather organic and based on a very, very small number of patients. But this was rapidly taken up by the liver transplant community and broadly applied across North America and indeed the world. Rationales, we mentioned a few. Again, these rationales were perhaps not well supported by the evidence. In fact, the evidence was that exists in the literature is of very, very low quality and quite variable in terms of how it predicts negative or poor outcome in terms of graft loss and patient survival. So we overall find that there's perhaps a little bit of evidence suggesting that there may be a higher survival in patients who are absent for 6 months, but that there was a lot of confounding in the data, and that perhaps this was not sufficient to base a hard and fast rule around transplantation. A question, of course, comes up, and that is that we don't really know what recidivism is or how we define it. And so, as Dr. Selzner mentioned, there's quite a great deal of variability in terms of the rates of recidivism that are reported in the literature. But in addition, the definitions that are used in the literature are also very inconsistent. So we have recidivism defined by categories: occasional, moderate, or heavy use. Recidivism that is very categoric, black and white, you are or you are not. Recidivism defined by clinical criteria, with or without biochemical testing, and relapse based on DSM-5 criteria for alcohol use disorder. So as you can see from the following tables, many, many different definitions are used, and so that makes combining data very, very difficult. I'm putting up some of the evidence tables that are used in this kind of work, just to show how each element was analyzed to look at the certainty of the evidence. Ultimately, the steering group formulated a recommendation around the evidence that we extracted from the literature, it's quite a systematic process that was engaged in, and this ultimately led us to 5 recommendations. So recommendation 1 is around the 6-month rule, and we suggest against using the 6-month rule as a sole criterion for liver transplant and alcohol-related liver disease. This is a conditional recommendation because the evidence around it is very low certainty. The 6-month rule is widely used and very straightforward to implement. However, our certainty of its prognostic accuracy is low, and there are numerous concerns about the equity, acceptability, and feasibility of its use, including legal challenges to its validity. The limiting factor for a strong recommendation against the 6-month rule is a lack of a clear evidence-based comparator with better prognostic accuracy, a demonstration that this alternative is feasible to implement and results in better outcomes. We note that alternative transplant criteria are being trialed across Canada and may provide clarity on this issue. And I think that the work that's been done in Toronto and locally in Alberta supports this. Our second recommendation is in terms of the definition of recidivism. So we make a best practice recommendation, and that is that we recommend that patients should be intermittently screened for relapse, both pre and post-transplantation. We suggest that patients with alcohol-related liver disease, that the definition should distinguish between harmful relapse, non-harmful relapse, and harmful drinking, and be monitored with the biochemical markers when available. We consider the 4 definitions but feel that more research is needed on the definitions as they impact graft survival, and highlight that AUD is a lifelong disease, and that in order to help our patients, we must engage and develop a relationship with them to work on this as a lifelong problem. Recommendation 3 centers on risk factors for recidivism. So we suggest that assessment of risk factors associated with post-transplant relapse during transplant assessment, including the presence of uncontrolled psychiatric disease, smoking history, history of multiple failed attempts of alcohol treatment, as well as protective factors, including social support and employment as part of the holistic and multidisciplinary approach, and allow for early intervention to mitigate risk factors. Once again, a best practice recommendation is also appended to this one. We suggest a holistic assessment for patients being evaluated for liver transplant that not only takes into account risk factors or other screening modalities, but a multi-pronged and multidisciplinary approach. Recommendation 4, use of scoring systems. We suggest the use of validated screening scoring systems as well as biomarkers to assess for relapse. We didn't specify which to use, as there are multiple ones out there and all of them have some validity. It is important to assess these risk factors to ensure early identification of relapse and early intervention. Recommendation 5 around interventions to prevent relapse. Again, without singling out a specific intervention, we do suggest that the use of multidisciplinary teams with psychiatrists, addiction services, are used to prevent relapse pre and post transplantation. Again, these are all these end up being conditional recommendations without great deal of certainty around the evidence. So with that, I'd like to open it up to a question period. I think that the recommendations themselves probably do not come as a great surprise, but you know, I take comfort from the fact that they really do take into account the state of the literature and are applicable in the Canadian context.
Well, again, thank you to both of you, Dr. Selzner and Dr. Chaudhury, for your time presentation. Greatly appreciate, very educational, and helps us to develop our care for patients living with alcohol-associated liver disease needing transplant. With that, we'll call the session to a close. A reminder of next Wednesday, February 21st, there'll be a remote seminar session presented by Dr. Megan Aversa, put in the chat as well, talking about lung transplantation and sensitized candidates, with the link for registration available in the chat. Thank you, everyone, for joining us this Wednesday, the 14th of February. Have a good rest of your day, and take care.